Hi, everybody. I'm going to give you a presentation about Team 4's work on vaccines and socioeconomic status. This work was performed by Erin Gill, Evelyn Liu, Grace Liu, Jeet Trivedi, Karib, Melissa Fuentes, Rachel Dunn, Sedrita Mitra, and Shrey Grover. So a bit of an outline. First, we're going to review the project statement, then go through the data description and resources, followed by project motivation, introduce our multivariate models, and then look over what is next. So the project statement, the goal of the project is to discover if there's a correlation between vaccination rates and a health region's socioeconomic status. And also if socioeconomic status is a good predictor for vaccination rates. Just a bit of background, there are 5 health authorities in British Columbia. There's Northern Health, Interior Health, Fraser Health, Vancouver Coastal Health, which is broken up into 2 parts, and Island Health. To describe our data a bit, data for each health authority was obtained from the BC Centre for Disease Control. The community health service area profiles contain metrics on various community health indicators like demographics, socioeconomic status, and health or disease status. And we were also able to access COVID-19 surveillance data, which contained cumulative vaccine coverage. The first thing we found out is that vaccine coverage varies quite a bit by health authority and also by age. So the different age groups are shown in different colors here, and the different health authorities are shown across the bottom x-axis. And the means and medians are shown in the different lines here, that different colors are for different age groups. You can see where Coastal Health has pretty much high vaccination rate for all age groups. The vaccination rate is quite different for different age groups in different health authorities. So a bit about our workflow. First of all, we downloaded data from the data sources we previously mentioned. Then we collated, cleaned, and formatted the data using scripts and Jupyter notebooks. We performed exploratory data analysis on the following groups of variables. The first one was the Canadian Index of Multiple Deprivation, or CIMD, which I'll introduce in a minute, and also variables that make up or comprise the indices listed above. So one would be the variables associated with ethnic identity and language. 2 variables associated with household size, detached housing, and state of housing, and 3 variables associated with education and income. Step 4 was we selected variables that were highly correlated with vaccination status to build a linear regression model, and then built and evaluated the linear regression model. The Canadian Index of Multiple Deprivation Factors are situational vulnerability, which are differences in socio-demographic conditions and factors such as housing, education, and other characteristics. There's also ethno-cultural composition, which is the makeup of immigrant populations within the community. There's economic dependency, which is dependency on the workforce or on other sources of income, and residential instability, so tendency of neighborhood inhabitants to change over time, while also accounting for characteristics such as housing and family. We also found that the CMID varies quite a bit by health authority, and while some health authorities are quite vulnerable, so 1 is quite vulnerable and 5 is least vulnerable. Some health authorities are quite vulnerable for some, and some health authorities are not so vulnerable for others. So we selected the following features for modeling that had high correlation with vaccination rates. Situational vulnerability, the percentage of the population identifying as Aboriginal, percentage of the population identifying as white, percentage of the population identifying as immigrant, percentage of the population identifying as Chinese, percentage identifying as Filipino, percentage of people whose education level is less than high school, percentage of population who speak neither English or French, percent of people who live in dwellings that need repairs, and percent of people that live in detached houses. Then we built a multivariate model, and we built the model based on the cumulative proportion of the population over 12 that has received at least one dose of vaccine. And that's because since the vaccination card system has come into existence in BC, there have been a lot of people who have recently been vaccinated with one dose, but because of vaccination rules, have not been able to receive their second dose yet, but likely will. We observed that individuals vaccinated the first dose is again, as I said, a better method for vaccine coverage. We observed that the percentage of detached housing negatively correlates with vaccine coverage, and the percentage of the population identifying as Chinese is also negatively correlated with vaccine coverage. We achieved an R-squared of almost 0.78 with an RMSE of 3.06. After removing some insignificant features, the model basically was reduced to a 7-parameter model. The biggest predictor of vaccine coverage was the percentage of population with less than a complete high school education. That model received an R-squared value of, again, almost 0.78 and an RMSE of 2.98. Some observations from our model is that the percent of detached housing negatively correlated with vaccine coverage, as we expect more detached housing in rural areas, and rural areas have less vaccine coverage. Indigenous communities were negatively correlated with vaccination rates. The relationship with Indigenous population disappeared in the multivariate model, though, as other socioeconomic factors are largely driving it. The percentage of Filipino population positively correlated with vaccine coverage, whereas the percentage of Chinese population negatively correlated with vaccine coverage. So some applications of this knowledge would be to assist health authorities in understanding factors that are driving vaccination rates, potentially amend policies based on targeted socioeconomic metrics that correlate with vaccine hesitancy, and potentially to ensure vaccine inclusion amongst populations of diverse demographics. So next, we'd like to create a dashboard tool for viewing vaccination rates based on ethnicity, housing security, education, and income, and also explore vaccination rates over time with relation to policy changes. And also, we'd like to automate updating of the dashboard as newest data becomes available. We'd like to acknowledge Dr. Sarah Otto for bringing forward the project idea, the BC Community Health Service areas for the socioeconomic data, the BC CBC for the vaccination data, and the Vancouver Datajam. And our roles are listed below. Thank you very much for listening.